Welcome to another interview of the International College of Dentists Leaders in Dentistry. Today we are delighted to have one of the world's experts and founder of the Branemark Osseointegration Center, an educator, physician, and family man, a person who has dedicated his life for the excellence of patient care. And today we're here with, and I'm in awe of sitting next to this gentleman, Professor Ingvar Branemark. Welcome, sir.
Thank you very much indeed. I'm delighted to be here.
Let's start early in your life. Let's talk that we know that you were born in Karlshamn, Sweden. Let's talk about mom and dad in the village and your brothers and sisters.
Okay. My father came from a farming region in very much southern Sweden, and then he went into business, and my mother came from a farming region slightly higher up. And the intriguing thing is that she was born at a farm called Branemark, which means you break the ground. There were a lot of stones and so forth. And then, when I went into osseointegration, I took the name of Branemark, which means that you break the ground.
Okay, and osseointegration, I found, comes
Yes.
from two Latin words.
Yes.
Which means make whole.
Yeah, but also it means that you can include in bone something that shouldn't be there and that it stays forever. And that's because what we are using, the titanium, has a unique coating of titanium peroxide gel. But in order to really be very honest scientifically, no one understands how it works, because normally you get a piece of metal or whatever inside your body, it's rejected. So it seems that the genetic code in the immunobiological system does not discover that we put it in if we do it very gently, meditative surgery, and then it stays there forever. At least we have an observation time now of 40 years. So the only thing also philosophically that will remain of our patients after 1,000 years is this little piece of titanium. So we thought of putting some little code on it so that, yeah.
Put your initial on to make sure they know who.
Yes, yes.
Well, let's go back to your family, because I do want to come back in depth into the osseointegration. Brothers and sisters?
I have two sisters. One is down in Lund, Sweden, at the university, has been training special pediatric nurses for all her life. And we meet this group, 25 nurses, every year because they are concentrating on severely ill children who are going to die. So we have a philosophical meeting each year in April in southern Sweden. And then I have another sister who is working at the cancer hospital in Rochester, New York. And she's been there for most of her life. And both of them are very dedicated to the care of severely ill patients, and basically those who are not going to live long. And I have learned a lot from them when it comes to considering what kind of treatment should we provide patients whose life prognosis is not that long. But also, my sister from Lund, who has trained all these nurses, she says that it's not the length of life, it's the quality of life. So that even if it's very tough for them, they feel that and believe that they do a very good and important job trying to make the final time as good and useful as possible.
So it's very interesting that your family has dedicated their lives to the betterment of the health of the people.
Even in situations where we can do very little, really.
Yes. Now, were the young days for you a happy time?
Oh yes, they were. You know, I studied in Karlshamn, and then after graduation I went to Lund to study medicine.
Excuse me, why medicine? What?
Well, you know, fact is that I first intended to go into engineering, but then it so happened that I really didn't like let's call it the technical mathematics that much. I wanted to use my hands. So that's why I switched over to medicine, and I was lucky, because it turned out that it worked very well, and I had good teachers, and I got a very good training, individualized training on patients with senior colleagues and teachers. And then it so happened that I became interested in circulation. And I did some experimental work. And Robin Foreus, who was a pioneer in sedimentation rate, he was available and gave some input. And then I just continued to try to look deeper into circulation and blood and hematology. So that's how I started to try to look over a long period of time into bone marrow. And at that time, titanium was not known. But I happened to ask a colleague who was interested in hip joints what he would like to have for his hip. And he said, titanium. Where can I get it? You can't get it. But then it became available from Russia. So I got it via a special Swedish company up north of Avesta and the nuclear site there. And it was just by coincidence I got it, and we used it, and it worked. And then the only problem was that once we had used it in animals, we wanted to take it out and move it, but we couldn't because it became integrated. So it was not at all intellectual. It was just by serendipity or whatever you call it.
Were there other gentlemen or ladies at that time that you would look back on your earlier days and say they were mentors? They had impact on changing the direction of your life?
There was one, Lars-Erik Jelin, who really introduced me into the so-called microcirculation, the flow of blood, rheology of blood in the microvessels. And then there was several, but there was one very important professor of surgery who came to Gothenburg from Stockholm, 52, when I started in surgery, Philip Sandblom. He died recently, 97 years of age. And he was the one who introduced me, because he was a child surgeon for congenitals. He introduced me into minimal tissue injury in surgery. So he was against the major cuts and so forth, very delicate surgery. And I guess that was the key to the fact that we could do the osseointegration.
Yes. And when you did your PhD, I noticed that your thesis was in bone marrow.
Yes, it was.
And so you really have put this whole package together.
Well, I started with bone marrow. I'm back in bone marrow, but now I'm back in bone marrow with the stem cells.
Yes.
And still I don't understand it, but it's exciting.
Well, and it works.
I believe we were very lucky when in the early days, already in 72, we started to put marrow, the patient's marrow, on the surface of the titanium components, so that we conditioned the titanium for this individual patient, and that might be one of the reasons why there is no rejection. Mm-hmm. And that's why it was so interesting to listen to Slevkin when he talked about the 0.1% difference between mice and men, because it may be that in this 0.1% lies the secret. Well, I don't know, but I think that it's a very subtle little thing.
We did Harold not too long ago, and he sure thinks out of the box in a lot of areas.
Yes.
Which is exciting.
Yes.
He ran NIDR there for many years and was
was
exciting to see. Now let's still continue, because I want to get into this other stuff in depth, but I want to complete.
Yes.
Tell me about your family, own personal family now. Your wife and sons and daughters and grandchildren.
Yes, I have. We are divorced, so my wife lives in France, but I have 3 children. One is very interested in linguistics and has been a teacher for immigrants from Africa. And another one, he is an orthopedic surgeon and has a base in technical physics. And then the second one, the boy, is really designing all the fine mechanical instruments and the whatever we are doing. So it's kind of, it could be genetic, but also it could be just continued craziness. I don't know what it is.
It sure sounds genetic to me. With a father like you, they got to be smart kids. Well, let's then...
or crazy.
Well, they say there's a short line in between where that is.
Yes.
Let's now talk, we've talked about your family, and let's now get into how you got started in the centers. And let me just read to you one thing. I know that your center in Gothenburg is at the Kalender Medical Center.
Yeah.
And I want to read you something I read about it. And it said, this small hospital has always carried out patient care with a warm heart and dedicated to excellence and uncompromised surgical and prosthetic rehabilitation, coupled with positive and caring patient interaction. Wouldn't it be wonderful if every provider, healthcare provider, would do that?
Yes. You know, we went there after having been working at the major university hospital, having units there, because they have 2,000 beds, you know, and it's like a major factory. And we wanted to be at a place where we could give optimal treatment even for the very seriously ill patients, but also where we could have time to develop procedures and so forth. It's a very small unit, only 25 beds, but with very good opportunities to do even sophisticated procedures, and the atmosphere is good for the senior colleagues who come. And I have had the privilege over the years to have a series of PhD students who were interested in the biology of healing. In fact, about 40. And many of them have become professors in reconstructive specialties. One of them is Ella Eriksson here at Harvard. Oh, yeah. And there are others, you know, for hand surgery and orthopedics and all that. But basically, we all shared a devotion in understanding tissue and the reconstruction of tissue and how tissue regenerates back to the original anatomy and physiology. And that is how we became interested, of course, in the stem cell. Because, I mean, the development of the fetus is what is repeated then in the healing of sophisticated tissue.
I noticed that one thing that it was very obvious to me, that this is a living process.
Oh, yes.
And that's exciting. I mean, for a...
Oh, you're quite right there. You are quite right, because at the interface between the dead material, which is not dead, because the oxide surface increases in thickness, but then between the titanium and the biologic tissue, there's a continuing exchange of energy.
Yes.
And I believe that in the future, that will explain to us how we can do this all over. But also, we can use that to understand the immunobiological mechanism of the body. So we can use it for therapy or reconstruction, but also to understand how can Mother Nature allow something to be incorporated without being rejected.
That shouldn't be there.
No, so that it works both ways.
Yes.
And it's very important that we have a group of people who are critical and put questions, and not just accept that 1,000 patients are treated and 1 promille is not working. That's not interesting. The intriguing thing is try to understand the mechanism so we can go on.
One of the things, and I was delighted they let me sneak into your lecture this morning. The thing that I thought was so intriguing from my background is that the brain is such an integral part of what you're talking about. And you did it specifically, beautifully, I thought, with the hand and the gentleman that picked the apples.
Yeah. You see, even with those who have lost a finger, they have the same perception and feeling with a prosthetic connected thumb as they have with the original thumb.
That's amazing.
And also, and he could pick the apple without having hand, but also those who have a high amputation, when they put on their prosthesis, they can feel what they are standing on, what kind of carpet. I don't understand it, no one understands it, but in the same way as we understand the interface, now this can help us understand how the brain communicates. And of course, the idea is obviously that we could use this communication to the brain, perception, and then back to the muscles to control computerized prosthesis and knee joint. So I believe that it's very important to have both the practical clinical fellows, orthopedics and so forth, and the very advanced neurophysiologists. and we are pleased to have it. But that it requires a lot of patience.
Both ways.
Yeah, it does.
Both
It does.
ways.
Yeah.
Now, after saying that, I'd like you to just give me a sense. You started the Branemark, or the osseo-integration centers,
Yes.
primarily in Gothenburg.
Yeah.
And then you're in 9 or 10 or 11
Yeah,
other
yeah.
cities in the
We are
world.
spread it
Tell me
around
how
the
that
world.
all got. Are these all trained in your center, and then you send
Yeah.
them out, or
Yeah,
tell
and
me
they
how that-
come. We have meetings a couple of times per year, and they come to us. We go to them, and we assist them in the surgery and see patients, and they send patients, and we communicate with video,
Yes.
which is very, very effective nowadays. I'm surprised, but it works very well, and you don't have to travel that much.
That's right. It sure saves you a lot. So the bone grafting techniques are also taught
Yeah.
in those centers.
Yeah, oh yes.
And
I've been around and traveling around and doing all the grafting surgery in about 150 cases. And that is
Yourself?
But that was when Barbara was with me. She's controlled. But see, that was very important because then I could exclude the surgeon factor.
Oh,
Yeah,
so there was one less variable.
and in fact, there's only one you can blame.
You were the guy.
Yes, of course.
So each of these centers then follow the same procedures.
Oh, yes,
And they follow
yes.
everything right
They
down
report, particularly when there are problems, so that we can immediately try to understand, can we prevent it? Is something wrong with the software or hardware? And that has been very beneficial, very beneficial. And you would be surprised how good they are in the so-called underdeveloped countries. We learn a lot.
Let me ask you a sensitive question, maybe. I read the list of them, and they're wonderful countries, big and very progressive, and there's none in the United States, are there?
Oh, yes.
Oh, okay.
We started here, but that was another kind of centers,
I see.
So we started here in Boston and with Elof, of course, and in Spokane and in San Antonio and all over, and there's one at Baylor. But that's another organization, that's all.
Okay, but it's
and in
this-
Seattle, yeah.
Okay. Because I read the list, and I know you're in
Oh, yes.
several in Europe, and now Australia. And,
Oh, yes.
And
Now we're opening in China.
in China.
Yeah.
Now let me ask you. Well, now you bring that up, I have a question I was going to ask you down the road. What do you do to relax, or is this? I mean, you have hobbies. You have very.
Yeah.
What are they?
I sit down and meditate and listen to to music, particularly Jussi Björling. Jussi Björling, the now 50 years since he died, but the famous Swedish tenor. I like him very much, and I use him also therapeutically for patients, when they're going to die. So I let them listen to some very special music by Jussi Björling. And
And you relax also that way.
Yes. And then I read a lot. I read, particularly, I'm very fond of Dickens, because that gives me a lot of English. But also, I enjoy reading him, and I can't understand how, with his medical condition, he could do all this. But he did, and I enjoy that.
Well, that's amazing to me that you have time to do anything else other than to concentrate on all these wonderful things that you've been developing.
Oh, I have good collaborators.
Well,
It's a matter of discipline amongst them.
they keep you posted. Now let's switch then to your serving humanity.
All right.
Barbara was good enough to send me a list of some of the honors and awards that you've received,
Yes.
of which is, I've done these interviews for a long time, and I've never seen anybody that's been recognized for deserving these awards as you have. You have, I don't know how many honor degrees, 10 or 12 and
20.
in probably 18 or 19 countries. You have.
Yes.
You're honorary dentist in.
Oh, yes.
Yes, and we like that.
I like it. It impresses people.
And is there any? Now, one of the ones that I just saw on a list that I thought might be interesting was the medal from Harvard School of Dentistry.
Yeah, you see, and I brought it here just
Oh,
because
okay, well, we can show it.
I felt very strongly when I got it in '92, because it says the rest of it is science and so forth, but there's something that I really believe in, and that relates to the care of patients. Health care means that you care for your patients, and that was explicit there, and I believe very strongly in that. It doesn't matter what specialty you are in, it's the care of the patient. And I feel that quite often we forget that in the teaching training of our students, because we get so technical and scientific and so forth. So I really appreciate that statement that is on this diploma.
Well, we'll show it right here.
Yeah.
Now, so are any of those other awards standing out in your mind that were all of them well deserved? That isn't the issue. The issue is that people gave them to you because they felt that your impact upon the profession of dentistry and medicine has been astounding.
Yes.
And
well, you know, I value all of them very, very much, but possibly what is really most supportive to continue is what comes from patients whom you treated, for instance, 10 years ago, and they still continue to send you and to communicate, and which means that not only the teeth are important, but also that they feel that we care. And you know, some of these who have tumors, we follow over the years, and then, of course, the tumor quite often takes over. And I've tried to communicate, which is very tough, as you know, but I've tried to communicate, and I remember a particular patient in Perth, Australia, with Patrick Henry, and he had lost most of his face, and we gave him a new face. And I followed him, and then when he was going to die, I called him, and I asked Patrick, what is the best term you have in Australia for a good fellow? Well, it's you are a good bloke. So I called him, Mr. McWhinney, you are a good bloke. And we both cried. And I think you read me now, because that is healthcare and not statistics. And I believe that we miss that in our over-enthusiasm of technology and whatever it is and science, because, I mean, you know very well that scientific truth lasts like that.
half-life's very quick, isn't it?
Yes. So I believe very strongly that we should help patients by training students to also take the very tough things, and that is what the senior doctors are obliged to do, but there must be time for that.
Yes. I noticed also that one of your interests, of course, is not only patient care, but the ability of the provider to talk to them.
Exactly.
Yeah,
yes, you're quite right there. That is what I try to say, that they should communicate. And you know, this is a little bit silly or childish, but I believe that when you do surgery on someone, particularly major surgery, you should always talk to the patient before they go to sleep. And I try to be there in the morning and to hold their hand and say that we're going to do all we can for you, and I wish you a good nap. I'll be awake, and then I'll wake you up in the evening. And I believe it's important, even important for healing, because they relax. And I believe in the immunobiological system, of course, and I believe that that's important. So it's not all pharmacology. There's much more to it. There's this interaction.
Yes. Let's talk about a term that I had not seen before, and of course I've been retired now and not seen a patient myself.
I'm also retired.
Well, you're seeing patients. I see. I haven't seen one in about 10 years. But the osteoperception concept. Tell me about that, because I think that's got to be something that's down the road, even though we may see some of it now.
I don't understand it, but fact is that I was so surprised when we did the first cases in the 60s, and they could feel what they were chewing when they had upper and lower. Discriminate, really, according to the standard stomatognatophysiological procedures. I couldn't understand it. But then when we started with hand surgery, and they could feel what they were taking and handling with their prosthesis, and with the neurophysiologist, we understood that there is a special mechanism in the bone close to the titanium fixture, which deforms slightly, and that affects the flow of interstitial tissue in some special channels, just 1/1000th of a millimeter in dimension, and that creates stress and strain, energy, and then nitric oxide. I shouldn't go into details, I'm sorry. But
no, that's fine. That's fine.
That then is probably what sends the signal to the brain. And then the brain modifies and sends via the motor down to the remaining muscles, whether here or there, or the muscular muscles. And it's remarkable the quality that can be created. And of course, we are now working hard, but that will take another decade to try to use that for the prosthesis. But I'm surprised that severe bruxes don't cause any trouble to the integration because of the direct connection. So I believe that sometimes, if they've had a serious perio and so forth, they don't feel as well with the original tissue as they feel with the direct connection to bone. And you know, to look into the future, to have a hand controlled by the brain, I mean the prosthetic brain, is of course, so if we can live another 20, 30 years, it might be a reality.
So you think in the, say, 2035, that could be a reality?
Oh yes, oh yes, oh yes, no doubt, no doubt.
It's always amazing to me. I recall, I said to somebody at lunch that I recall as a young man hearing about Buck Rogers and his ray guns.
Yes.
Well, Buck Rogers is real. He's here today with us. And of course, the lasers. Does the titanium ever reject that you're aware of if your technique is used? I mean, if the technique of good surgery and proper, it stays. It stays.
In fact, it's impossible to remove unless you cut it out. That's the only drawback, that you have to cut it out brutally.
As I watched this morning, the thing that truly was amazing to me, and as I say, I don't have to go to continuing education or anything anymore, but it was just, it's one of the best I've ever seen. I've been going to them for 40 years. To see the person walk when you put in the femur.
Yes.
That lady.
Yes.
Was truly a miracle.
Yes, yes it is, and we still feel it is a miracle. We don't understand it, but they have to be very dedicated and trained very much. So you must pick the patients according to their mental strength and so forth. But then, you know, I can't understand how they can feel what kind of carpet they are walking on and how they can dance and all that, whatever they are doing. And those who have lost both limbs, it's absolutely ridiculous, but it works. And that is, of course, how we can then use information from those patients to understand by recording the activity of the brain to see if we can get that then into a computerized knee joint or hand and so forth. And there are new hands coming. Now of course, what those are available are just very, very rough and so forth. But now this will come. And I believe that it's a matter of being patient. Someone asked me today, why did we wait from 65 to 82 until we released the osseointegration here outside of Sweden? And I said that, well, you know, fact is that we wanted to be as sure as possible that there were no untoward effects after a long time and so forth, and that the patients could collaborate. So fact is that Swedes are slow and stubborn, but not necessarily stupid.
Well, and the success of, I recall when you did that in the 80s, the success of why we chose that here in the United States Navy was because your data of success and longevity was sound and very hard.
That's why we waited.
Well, it was the thing that sold us at that point.
Yeah.
And it's so important to see that you learn from some of the failures, but...
Oh, yes. I believe there should be conferences now and then on failures and complications and mistakes. I mean, everyone has success that can show nice percentage and so forth, but we should share when there are problems. Why should others repeat our mistakes? I don't see any pride in or prejudice, whatever, in trying to hide that. And I believe very strongly that senior colleagues should take initiative to having these symposia. Could be closed, could be very discreet and so forth, but really have our colleagues report. I believe that would improve medicine much more than governmental checkups and so forth, because you never get the true figures, of course.
You made a statement also that I think is an interesting one and gets a lot of debate around some of my friends, is the interaction of dentistry not only as a tooth dentist or a mouth doctor and a physician of the patient.
I'm so pleased that you noticed, because I believe that craniomaxillofacial rehabilitation dentistry should work together with hand surgeons, because hand surgeons and what is done here require the same precision, and there is no competition but a lot to learn across. And in fact, I believe that we can learn a lot about the brain from this region and this region, because they dominate the brain. So I believe it's a waste of possibilities just to put up walls between those disciplines. And I believe for the future, there also we could have the international video conferences and so forth.
I think it'd be magnificent.
Yes.
Now, one other area which I thought was really very interesting, I happened to have just spent a couple of weeks with a fellow that couldn't hear worth a hoot, and it was tough converse. It was tough even playing bridge with him. You almost had to shout at him what the bid was. The new system that you're using with the ears and the hearing aids, relate that, how'd that get going? That's fantastic.
Oh, that was very interesting. There was a Finnish fellow called Timo Makinen who had an upper graft and then fixtures. And we thought we would like to have some kind of numerical appraisal of how this did function and the connection between titanium and bone. So we simply used a hearing aid, one of those, vibrators, and put on. And of course it was silly scientifically, because that didn't give the figures, but of course he could hear. And then, since we were working with the ENT fellows and having a lot of these congenital and senior ones who needed, with the spring and all that, and sending the signal through the skin, and which destroys the quality, we thought, why not put a fixture here? So we did, and it works lovely in the congenital and also in the elderly. Now there are a lot of variations of this, and then and this is remarkable, now you would say that what you do is you shake the brain, that's all. No, because if you put one on each side, they get directional hearing, they get stereo hearing. No one can explain how, but it's a fact. And that can help us possibly to understand also the mechanism of the inner ear.
Yes.
And it works. And if they turn a teacher calling syndromes, for instance, in children, it's of course very crucial. Already when they are 1.5 years old, we put in fixtures so that they can start hearing and can learn the language and communicate and so forth. We don't wait until they are 5 or 6. And in the early days, of course, But now that's a routine all over. And it's remarkable. And I still remember, it was in Brazil. She was, I think, 35 years. And we put on these, and then she got the hearing aid after healing, and she went out, and then she came in and said, I can hear the wind.
Yeah, oh boy.
And that's quality of life. Now, and also philosophically, we don't understand it. We don't understand the mechanism, but we understand a little bit how to do it, but particularly we know that could be helpful. Yeah. So, all right. So, science without clinical follow-up and documentation is very good for universities. Now I am very aggressive, sorry.
No, that's fine with me. Let me also give you a perception that I had this morning that was amazing, and as the older I get, the more I see it. But when I saw the ravage of disease in some of the patients you saw this morning, what I have happening to me is zero compared to those poor folks. And yet you were able to bring a smile back. And just a smile is amazing to some people. What amazing stuff you're doing.
Now you see, and you put your finger on a very important point there. We cannot bring them back to the origin.
No.
But if we can bring them back to a situation where they are strong enough to stand up and talk to people and smile and communicate, then that is all we need to go on.
And every day for them is just fantastic.
Yes,
Yeah.
That's right. Otherwise, we found some of these patients hidden all over the world, hidden because they were out of business, as it were, and nothing could be done. And it took 10 years, I guess, to get these centers working. But now it's remarkable. And you need something very important. You need the anaplastologist, the technician who can make something looking like a face. And I'm impressed by them. So it's teamwork, surgery, pros, and so forth, and also all the time having the basic scientists available to listen and learn. And of course then they can get ideas and they can help us understand if it works. And if it doesn't work, that might be even more important, because that
then
could
you're
give them
learn more.
Yeah.
Do we have a problem recruiting people to do research like this? I know if you looked at the room, 5,000 people, or I don't know, they were sitting all over, they were jammed. Most of those people were using this as a pocketbook issue.
Yeah.
Do we have problems getting those dedicated people to come and do the research that's so essential, and admit defeat and admit failure and to join you? I mean,
that is the key issue you bring up there. And I believe that university, but particularly the senior clinicians, could start listening to the young ones, because instead of blaming them for some mistakes and so forth, they, by listening to what the problems the young ones have, they could possibly understand how we could avoid it. And so I think one shouldn't blame them. And I also believe that we should help them as mentors. We should help them as mentors to pick a scientific problem and work on that, and make them understand that it doesn't have to be magnificent. A small piece of information is possibly what we need to go on. Yeah.
And that's the team.
And that team and centers.
Well, boy, your impact has been truly amazing, and I'm learning more and more. The opportunity I've had to study your centers in your life has been a real joy for me, and you're going to hear people shouting it from the housetops. It may be me, because I just think that it's... Now, let me ask you a question. A young man or woman in Gothenburg comes into your office and says, Professor, I want to go into this field. What would you suggest I do?
I've had many PhDs now, 40 or something, and I have learned over the years that most of them have the brain for it, but do they have the patience? Do they have the energy to go on after failure? And if it, quite often it fails completely. It turns out it was not possible, or it doesn't fit, and so forth. Can they take that, or do they feel I lost a year and so forth? I believe that whatever they do, they don't lose time. They learn a lot, but it's a tough decision. I've been very happy that most of those who have come to me have spent 4 years with me, or 5, and then done a very good job and left out, and all of them becoming active in clinical work. But I believe that one must try to understand their psychology.
Yes.
They must be very persistent and very stubborn.
Primarily stubborn.
I believe it. No, I believe it.
Yeah.
And I think that that's what's wrong with the situations where they believe that they can sit by the computer and solve all problems. So, I had a rule when I was active in this training of PhDs. You should see at least one patient a week. And then when you have got your PhD and you got your specialist, you go out in a countryside hospital and spend 1 year out in reality, on duty. Then you can go wherever you want. And could I take as an example, Ella Fredriksson, the fellow at Harvard? He spent a year in a small hospital on the east coast of Sweden. And you know, I think that was the key to him to become the excellent fellow he is. And others also have done the same, orthopedic fellows and whatever. I believe that what we are missing now is this over-enthusiasm for advanced, let's call it intellectual medical research. Patient. And when you see patients, you understand the complexity, but you also understand that even a minor contribution could be very, very important for what you said, make them smile again, whether they have lost a limb or whatever is the problem. Yeah.
The rubber hits the road has a certain impact on your wisdom and discernment, and I think primarily in your developing the prognosis. The other is purely academic, but that person, see, you're getting back to what the old patient. You know, that's the center of everything we do, and we forget that many times.
And still, you know, I see patients I treated in 65. They are very old, of course, but they come, and of course, I enjoy it. I learn a lot, and that to me indicates that in the training, even of the super specialties, patients, and bring ordinary patients, so that they see the daily, you know, of course, that 95% of patients who come could be treated by the local doctor. 5% need to go to specialists. And now it's almost the upside down.
One of the new, the exciting developments that you've done at your centers is the same-day teeth.
Yeah.
Give us a little insight into the same-day teeth. I think that's wonderful.
Well, you know, I had the privilege and pleasure of working with Richard Scarlack, who was at Columbia Bioengineering and then went to La Jolla. He died a few years ago, and he worked with me since '68. And he said that I believe that it would be better for you to do this in 1 day if you could connect them with absolute precision immediately, so there is no undue talk on the individual one. And we started talking about that in 1980, and then it took until 1996 because we are slow, and then we did it, and it worked. And now, of course, I agree with him. He's following from upstairs, and you know, I agree with him that what we did was that we put them in such a manner that we could start loading the bone functionally immediately. And then the bone remodels, of course. Because if you put in a piece of titanium here or there and don't apply functional load, the bone doesn't know what you ask it to do. So you should apply control load. And that is what we are trying to do even for these now, but particularly here. And that works very nicely indeed. And also, it's a matter of cost. I mean, you think about, I enjoy this. We started to call it the China Bridge from the beginning because we felt that in countries like China and India and so forth, you can't have this sophisticated, westernized, I mean, you wait 3 months and 6 months and all that. So if you could do it, and not just drive in, but almost, yeah. And now we can do it.
Drive in. Because it's what they want, what they need, and what they can afford.
Exactly. Oh, you.
I listened this morning.
you have a good brain still. No, but I'm serious.
Yes.
We are obliged to that,
yes.
Not to sophisticate unnecessarily.
Simple is better. I recall you saying that.
Yes, and it is.
And why do we have intelligent people out there in our clinics that may be trying to make everything? Is it a bottom line of a pocketbook issue? Or I mean,
not necessarily.
Not necessarily.
But there is the competition between universities. And then there is a competition between the grants. You know very well that,
sure.
that is... I must also say, and I'm very serious now. I had the privilege and opportunity in the very early days, in the mid-50s, to get a substantial grant from NIH for studying bone marrow. Without that, we wouldn't have been sitting here. And I really remember that, and some of those who participated and helped me get that. And that was the base for it. And that was just because someone thought that there could be something behind what we were observing in the marrow and so forth, and that would require a very long time follow-up. So that gave us resources to build microscopes and so forth and so forth. And it seems to me that, and I've argued about that, the short-term calendar, as it were, for basic research, that you ask for resources for the year, and then you report what you achieved, whereas you should have had at least 5 years perspective. Yeah. But it's very difficult to really convince the authorities.
Especially through the NIH process. And do you recall who the director at that point was?
No, I don't, but I remember the faces of them. I was here and talking to them, and I was surprised that they didn't listen to a young Swede.
I'm delighted that we know that some of our tax dollars went to help you develop this stuff. I think that's wonderful.
Yeah, no, but also they had some fellows who contributed scientifically, and now, of course, we have coming close to the interface and the surface energy and Adrian Pasidian there. I mean, it's remarkable. We are back again trying to understand really the submolecular and Chuchen in La Jolla. So I think that, well, it takes half a century. So what?
Let me ask you another question that I'm sure you might have some ideas on. We as a people are teeth and bodies. Now, we also have dentists and physicians. Wouldn't it be better to look at us and train us and maybe try to have impact of both on each other as a group instead of just we're parochial in our own little focused areas?
You know, the problem is that in countries where they've tried to bring together, they don't allow enough time for teaching training in the medical part of it or the dental part of it. I think I would have to reorganize the education, but then I believe it would be beneficial, at least for those who would like to have a broader aspect. And I think that that's for the future, because otherwise we will split up further, and we should unite. And let me go back to the reconstructive surgery and so forth. I mean, we use the same basic principles in all parts of the body, in the skeleton, for instance. And you know, if we now consider the stem cells, they're moving around. They don't know what we ask them to do until they reach a region where there is a factor calling them to locate and to start forming things. And to me, it's ridiculous to split it up for organizational or administrative or whatever matters. And I believe that there could be a promotion from dentistry to medicine and medicine to dentistry. And there is no pride in this, but the problem is how to get it organized. It has been tried, but it's very difficult to do. And that's why I now quite aggressively suggest that you take this part of the body and this part of the body and you work together. And I talked to the, at that time, president of the American Association of Maxillofacial Surgery, because I became a member there, and he said, well, you know, I think there's something in your idea, so I'm not against it. And I'm fighting for it all over now.
Well, may I tell you that in the Navy now, oral surgeons are getting dual degrees.
Really?
Yes, we have.
Oh, that's encouraging.
Yes, they become their dentists, oral surgeons, and then they're geting medical degrees at the same time.
Lovely. I'm very pleased to hear that.
Whatever you started way back has been seeded into something. And
I follow the stream.
Well, the oral surgeons, I think, at least in my impression, have been ones that trigger it. Because, and I think it came out not so much of the eagerness to to maybe look at treatment, it became out of the willingness for JC, the hospital accrediting people, to let them practice in hospitals. That's where it came.
Yes, of course.
Yeah, that's where.
And you know, let me give you a practical example. Now you have a very serious defect here of any sort, tumor or trauma or congenital or whatever. You need to have all the specialties available, and you can't have everyone. So you need to have a few who are concentrating on this part of the body, and then the oral surgeon, maxillofacial surgeon, and some of the reconstructive surgeons say, well, should join forces there. You can't do it by yourself,
No.
and you need someone to communicate with when you decide, make the serious decisions what to do and so forth. Let me give you one example that I have been observing is that when you resect the maxilla, quite often, because it's old tradition, you take most of the zygoma. But if you save 2 millimeters, it's so easy to provide anchorage. And at the same time as you do the resection, before the patient wakes up, you have put in two fixtures, and you put on the operator, and the patient wakes up and says, did you remove? Ah.
That's right.
Yeah, you see? And
just
that
2
is
more millimeters.
Yeah. That is what I believe is so important. And it's not the fault of the oncologic surgeon, because they were taught by Obigus and others to do it this way. But you know, you just save, let's say, 2 or 3 millimeters, that's all. And it doesn't affect radicality, of course, no.
Well, you also found out something in the sinuses which showed that the infection wasn't as it went through the sinus.
No, because it's sitting not moving, there's no relative motion, and there is a formation of a titanium peroxide gel which counteracts inflammation. And it's remarkable when you look into these after 4 or 5 years in the sinuses. It's absolutely normal mucosa, and it doesn't react at all at the presence of titanium. And how could we know? So when we did the first cases, of course, it was said that we were absolutely irresponsible. And I had some cases in I think it was South America, where in congenital defects, where the patient went to some ENT fellow, and he said, oh, you have something very bad in your sinus, so I'm going to remove it. He did, but he got a major defect, of course, but he did.
Yeah.
And how could he know? But that indicates that there is kind of prejudice against new procedures, and of course we should have informed and so forth, and now everyone knows. But I believe that if we have adequate long-term follow-up, then it's right to suggest it. If we don't have that, no. Even if we are believers, I think that one should wait until you have documentation. And from several quarters, that's why we have the centers. You ask for centers.
Yes.
The centers are there with senior people, very critical people, who tell us, no, we don't believe that this is working correctly, so we have to modify or we have to skip it. So
Do you have other centers online
yeah.
to come on?
Yes, all over the world we have now, but we would maximize to 15 to 20 in order to be able to communicate. But now, of course, with the video technology, it makes it easier.
Because if you're going to go to all of them, you're busy.
No. I've traveled it
You're going to
out.
get 1 million miles, travel miles.
No. But and particularly in India and China, of course, where, and you know, in India they have all these tumors because they chew the metal.
Sure.
And the 35 years of age, you have to remove the entire maxilla. And then, you know, if you can do it in one step, you see, 1, 2 fixtures, obturator, teeth, thank you very much. And then you can easily remove the prosthesis and check the tissue if the tumor has recurred. Yeah. And I believe one should do it as simple as possible. And if you apply in the majority of these cases, microvascular grafting and so forth, I think that you overdo it, and also you might hide the recurrence of the tumor. So I think one should be realistic. And also, how could you provide more than thousands of these, of course, provide them with something? You could possibly do, I don't know, 50 or 100. But that wouldn't really help them better than if you, yeah. So I think that one must be realistic and reasonable and see in the local situation what can they do.
Public health is a pretty significant thing nowadays, especially for those countries that can't have the wherewithal to support it.
Yeah.
It's expensive to do it. Just a comment, I was having lunch with a fellow I hadn't seen in 20 years, and he's a periodontist, and he said, you know, I've learned so much from the professor because when he showed me how to drill the hole better, my cases are more successful.
Yes. You know, something that very few people know is that bone can only take 42 degrees centigrade. If you go above 42 degrees centigrade, you kill the capacity of the bone to heal again, and you kill the stem cells.
So we're heating them up too big or too high.
So if you remember the old days when we did hip joints, and even here, of course, you got up to 50, 60, 70 degrees. And then, of course, you had to wait for rejection. So I believe that that is exactly, and that is why perio sometimes is a good background to do gentle surgery. Yeah.
He said that to me today, that was a success.
Yeah.
That one pearl you gave him put a lot of money in his pocket. But,
could I have his name?
Yeah, I'll be glad to give it to you.
I mean,
he used to work for me.
Concerning the pocket money.
Oh, well, he's got plenty of it. In fact, I had one of our friends here from the International College. He even talked.
I'm sorry.
No, it's okay. He's done well. But I thought that was a wonderful comment from feedback for the effort you make to go out and tell people and to pass the word and to get those precepts out to those people is so important because there are those people that are looking to do it right for a different reason, maybe.
Yeah, but doesn't matter.
Yeah.
We should tell them what we have learned. And when we had failures, that's why I advocate for meetings on complications and failure. Yeah.
Let's look to the future now a little bit. I know that the stem cell is certainly it's a vogue term in the United States. I just had a friend that had his stem cells taken for multiple myeloma and replaced it. He had 7 million of them.
Yeah.
You're doing research on that, I know now.
Oh, yes.
And can you give us a little future where you think that's going to go?
Well, Gothenburg was selected as one of the key places in the world by the NIH and so forth for stem cell research, and also in Sao Paulo, the cancer hospital. So we're working together with them, and we are particularly interested in the irradiated patients, what happens to stem cells in radiation. And my feeling is that it's premature to believe that we can use it in daily patients and so forth, but I believe that that will give us opportunities to improve the present procedures, and also, as Slefkin said, in the future, with the genome and so forth, to really recreate even sophisticated parts of the body. But we must remember that the over-enthusiastic reports on making ears and whatever, were very premature, of course. Yes. Yeah. But part of this can be used in addition to very gentle surgery. So I think that meditative surgery is a good term. You can listen to your Sibjörling while you do it.
That's right. That'd be great. Now, other than, say, the stem cell stuff that you're looking at down the road, any other directions that you see might be open, might be advantageous to us that you're thinking about, just meditating about at this point? Say in 2020, or are there other lines of research that are coming to sight that haven't been really looked into carefully enough yet that you could reiterate for us?
I believe that with the growing age of people and the increasing number of those elderly who need hip joints and knee joints and I don't know what, I believe that we must find or develop simplified procedures that are safe and that can be afforded. So I think there is a need for that. And also, since you asked me, let me give you something that we are now really working hard on, and that is a project where edentulous, some of them are 50, 60, but they are edentulous, and then they get a stroke. And you activate arms and all that immediately, because that's now what we do. But our idea is, since such a big area of the brain is representing this part of the body, we believe that same day as you diagnose stroke and the identities, you put in the novum. I mean, 1, 2, 3, 4, put on the bridge, and then you put them on this exercising machine, so that they send signals to the brain, and there are indications that this would help them recover better.
Okay.
And this is something where I feel that we could do a lot of good with minor procedures, and where dentistry and medicine would work together in a meaningful way. And it would not be, we call it the Hollywood smile, but it would be something very deep, personal to the patient, and particularly to the supporting personnel and the family. Yes. Because, you see what I mean, of course. Yeah.
Oh, yeah. How about any new developments you might see in the healing area, instrument developing, some of those issues?
Yeah, I think that there are a lot of new instrumentation that could prove helpful, but I don't see at this. One has tried electromagnetic and so forth, and whatever stimulation, bone healing. But I believe that the gentle surgery is the best choice anyway. It's sometimes I feel that it's kind of cover up or make up or whatever for brutal surgery. But certainly there is a possibility. But I believe that that might not be the major effort, or should be the major in the near future. I think simplify, make it cost effective, so that as many as possible can get it. And you know very well that hip joints that fail are very bad, and they should not, of course, be caused by contamination of the product, but also that if you have to do a hip joint in a 40-year-old one, it might work for 10-15 years, but then it fails, and then if you redo it, 20% of those you redo failed.
Yeah.
And that is a terrible, terrible problem when now people live until they are 80, 90, and they have the fracture, so they need prosthesis, or they have the arthrosis. So I think that perhaps we should, I'm very pleased to ask that, I think we might also try to lower the ambition level a bit, and try to see what could we make available for the ordinary patient, even if this is not the most sophisticated or scientific and so forth, but which would make them have an acceptable quality of life. I remember in the very early days, because during the war, Second World War, I was moved up to sometime in mid-Sweden, because of there was the fear of German invasion in Sweden. So we were moved up there, and then I still remember a man. He was about 75 years of age, who fell, broke his neck of the femur, and nothing could be done. So he was sitting in a wheelchair. And I remember him because today he would have been treated overnight, and then went home and walk around.
Right.
And that would have been cost effective, and it would have been good for everyone. But now it may be that we are aiming a little bit too high. Yeah.
Let me ask you a question that I love to hear responses, and I tried to, even though I asked the question, I've always thought about it myself. What do you want to be remembered for? Now, you can take your time on that one, but I think I know what your answer is going to be. But if your grandkids said, "Grandpa, what do you want to remember for while you were on this earth?"
I've got that question several times,
okay.
And it's a very difficult one. But I think that what I really would like to be remembered for is that I managed to to give some people a better quality of life, and not for scientific advances and so forth, and particularly that those who I've trained over the years have accepted this philosophy. And you know, most of them are very good doctors in the old sense of Hippocrates, yes, because they see the patient as a fellow being, not as a statistical number. So very seriously, I would put that would be something very, very, very meaningful for me if they could remember that I tried to convince them that you are here for the patient and the patient is not here for you.
And I guess I could throw in from just the outsider point of view that you'll be remembered for your dedication to making it better, and by sharing. You're sharing information with others that have the opportunity to maybe do the same thing that you've been able to do, so that we're multiplying that, not arithmetically, we're doing it geometrically. And
I see what you mean, yes.
That's something to be remembered for. And I was astounded at the response of those 5,000 people this morning. The way
but
they
you know,
thought
they
of you.
have a heart for their patients.
Yes.
I
Well,
mean,
you've given them that, some of that.
They are there for their patients. And even if there's a lot of business and all that, you know, you have to survive. Still, when they see a patient who can relax, and let me summarize possibly, you have patients who have spent a lot of money and time to try to keep the original teeth. A lot of money on bridges and all that, you know, but they're doomed, because there are those cases that are doomed, and they come and use the tongue to hold the bridge in position. And if they move the tongue inwards, it drops down. Then we have found that now, in certain cases, it's possible to put them to sleep in the morning, to remove the bridge, to correct, and then certain procedures, put in a couple of fixtures, put in teeth, and then in the evening they can leave and
chew soft food. Yep.
That, I believe, is going to be very important, because if you think about how they have had sleepless nights for many, many years because they feared and they knew someday I'll wake up and I'll have a denture. So I believe that, and also that, I'm not a dentist, but that is possibly why I respect dentistry so much, particularly I care for these patients. And you know, since you asked me seriously, I tell you that in the training in medicine, when I was a young man in 50s, we were taught, you know, to write the reports, and we said to the patient, open your mouth, huh? And then we said, denture, upper, lower, tissues all right, and then we said nothing more, instead of really trying to understand how this affected not only the stomach and so, but also the total social situation and the peace of mind.
Yes.
And I wonder in psychiatry if they understand more. So I think that replacing, to provide a third dentition could sometimes be a much better psychopharmacon than those available.
Yes.
And I feel very strongly
And
for it.
personalities would change, and
Yes,
behavior
yes.
would change, and
Yes.
smiles would change.
Yes.
Make the place a better place, a better world.
Yes, and more confidence.
Yes.
Because you lose your teeth, you lose jawbone, and you lose your self-confidence. And that's why I fight for dentistry in combination with the rest of it. So
We consider you a dentist, and if somebody
thank you very
says
much.
you aren't,
But you
just let us know.
cannot treat the patient in the articulator.
No.
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 All right?
Well, I have just considered it a real joy to sit here with you this afternoon.
It's mutual. And you noticed that I caught on.
You are just a magnet. You know, the joy of looking at somebody like yourself that has donated and dedicated their devotional life to people is why we go into these professions. And and thank you for doing that. Thank you for sharing that.
Thank you for your comments.
And thank you for your time this afternoon.
Of course.
You've been on our list for a long time to try to get here. And I'm glad you came to Boston, not only for that meeting, but for the International College's program, because you are a leader in dentistry.
I enjoyed it, and also had an opportunity to philosophize on why are we here
Yes.
in healthcare.
Yes. Thank you, sir.
Thank you, my friend.
It's my pleasure.
This is also a kind of integration. Thank you.
Yes, it is.